Okay. So today I'm going to speak to you mainly about Epstein-Barr virus infections in the normal host. Although there certainly are implications from the history of the disease and the discovery of the virus that's the major cause of it for chronic serious conditions such as autoimmune disease and cancer. So the title of my talk is Epstein-Barr virus and infectious mononucleosis, What Students Can Teach Us. And I have a disclosure. I had, past tense, a investigator-initiated grant from MedImmune, and part of the reason for that grant was to work on an EBV vaccine, which sadly, again, has been put on hold. Our group is relatively large, and I'm very proud of them. I've listed them all here, and they number 28. We have a virology lab, a virology clinic, an immunology lab, and a group at Health Partners. And the Rogues Gallery is here. I won't bother to point out everybody. You'll probably recognize a couple of us. And these are the people who did not pass muster and couldn't come to the group picture, so we put them in as a collage. What I hope to impart to you folks today are these learning objectives. Describe the epidemiology, clinical and lab features of primary Epstein-Barr virus infections, and then recognize both the unique aspects and the potential problems of these infections in children, and discuss a little bit about where we stand with hope for developing a prevention or a treatment for Epstein-Barr virus infections. And the way I'm going to approach those objectives is with the following outline. We're going to talk about medical history for a bit, the discovery of Epstein-Barr virus and its link to infectious mononucleosis, then go into a review of studies that we've just published on university students in mono, then specifically talk about younger children, pediatric patients, and what we can learn from them about this virus, and finally talking about immunization and treatment. So we start off, and it's interesting how history weaves the story together with very serious disease and acute illness that doesn't amount necessarily to much, and that is that way back in the 1920s, Sprunt and Evans described at Johns Hopkins Hospital the clinical entity of infectious mononucleosis, and the reason that was important at the time was that this was readily mistaken for leukemia, which of course in those days had absolutely no therapy whatsoever. Then at the University of Minnesota, our very own Hal Downey, who was part of the Department of Laboratory Medicine and Pathology, showed that there were very typical cells, which are called still to this day Downey type 2 cells, which we know now are CD8 positive cytotoxic lymphocytes. And these cells are specific really for mono, but nobody looks at peripheral smears anymore. And so we're doing different tests. But Hal very nicely showed that these could be distinguished from morphologically from acute leukemia and other types of dyscrasias that were much more serious. So the atypical lymphocyte and the clinical syndrome were now known in the 20s, but we had no cause. Then workers at Yale developed the heterophile antibody test, and heterophile really simply means it's reacting to something that's not specific. In other words, the test that's giving you a positive reaction is giving you a positive reaction to something that's not causing the disease, but we think in mono there's a general upregulation of the immune system such that we make IgM antibodies to a number of types of mammalian red blood cells, beef red blood cells, sheep red blood cells, and the like. And so there's now a laboratory test as well as a hematopathologic description of what's going on with this disease. And we have this information in the 20s and the 30s. Now, the next piece of the puzzle was that Dennis Burkitt, a British pediatric surgeon who was assigned to Africa during World War II, stayed there after World War II, and was responsible for discovering a strange jaw tumor that was a lymphoma in young African children, and it was pretty much fatal. And so Dennis Burkitt described this tumor that to the world of medicine was pretty obscure, pretty arcane, not really of a great deal of interest, but he tried to drum up some interest, and he went to London lecturing, and he ran into Tony Epstein, who heard his talk, and asked Dennis if he would send some of the tissue from Burkitt's patients to Tony's lab. They were doing electron microscopy in those days. They were not doing cell culture necessarily, but they got into cell culture fairly quickly. And what they showed, Tony Epstein's group, was these virus particles that are very complete herpes virions and incomplete particles here, publishing this famous work in The Lancet in 1964. And so here we have a herpes virus associated with Burkitt lymphoma, but not associated with mono. And the people responsible for this are Tony himself, who's still very much alive and a wonderful person, Bert Achong, who's no longer with us, and Yvonne Barr, who after the work was done, left London and never engaged in medical research again. But I just want to point out for some of you people who are involved in bench or clinical research that we've got three people here, right? We've got Tony Epstein, Bert Achong, and Yvonne Barr, and yet this is known as Epstein-Barr virus. So for goodness sake, if you're working in publishing, try not to be the middleman, because you may not get any recognition whatsoever. Okay, so we've got cancer. We've got the viruses in the cancer tissue. We've got a disease that's very interesting and may at times look like leukemia. It got all put together, and it got all put together by the Henleys working at CHOP, Children's Hospital of Philadelphia, in the late 60s. They received tissue from Tony Epstein, and they tried to get this to grow in their laboratory in various cell lines and failed. It failed until one of the technologists, who was a regular donor of lymphocytes, developed heterophile positive mono. And when she came back to the lab 6 days later, boy, her boss must have been a slave driver, because mono lasts longer than 6 days, but she comes back. She donated her lymphocytes, and holy cow, they grew. And they showed, as you can see by the serologies here, that the cells now were positive for EBV antigens, and the heterophile goes off the map. And so we have a very fortunate thing of someone contracts mono, has been a donor, and we now know that anybody who's had EBV before, their lymphocytes can be immortalized, but this was just a lucky thing. Quickly, they went to Yale and to West Point in New York State and got sera from people that were interested in mono as a clinical disease, and were able to show rises in acute and convalescent sera, clinching the deal. Well, the government actually intervened. You know, I'm from the government, I'm here to help you story. And this is actually a quote from Gertrude Henley, who said, because EBV turned out to be one of the most widespread human viruses, we suspected that it might induce a common illness as its primary clinical activity. And then, in our search for this, we were assisted beyond the call of duty by one of our female technicians who was seronegative, developed infectious mono, and seroconverted in its course. This was not a laboratory infection, as proclaimed by the Division of Biologic Hazards of the NIH. Our technician was a very pretty girl, and thus was exposed to the kissing virus by the natural route. And there she is, there she is with Harold Zerhausen in the Henley lab in 1968. All right, so let's move on to the second piece of my outline and talk a little bit about what we've been doing with University of Minnesota students. And what we've been doing with University of Minnesota students is a series of prospective surveillance studies where we take freshmen and we screen them for Epstein-Barr virus antibodies, both for the viral capsid antibody IgG and the EBNA-1 IgG. And those who lack antibodies are eligible for surveillance. And this shows a couple of our kids recruiting at Territorial Hall. They're very good. The health advocates actually make these posters up, and they're a great help of shooing people through the door and getting them to come in and give samples. So what we do is, for the individuals who we know are seronegative, we want to find out what are the risk factors for acquisition and severity of primary Epstein-Barr infection. And to do that, we see them at least every 4 weeks. The first two classes we studied, the class of 2010 and 2011, they've graduated now. We saw them every 4 to 8 weeks. But the class of 2016, whom we're with now, we're seeing them every 2 weeks, and we obtain blood and an oral wash, and we bank this material and batch test it. If they report illness, either by internet or cell phone, we schedule extra visits to check them out. And if they are laboratory confirmed primary EBV, then we see them very frequently for about 6 weeks and document the type of disease they have and collect samples for special immunologic studies. We also perform a health questionnaire monthly where we ask about nutrition, stress, exercise, and sexual activity, of course looking for risk factors for acquisition of the disease. And the punchline from the class of 2000, class of 2010 and 2011 was published just last month in the Journal of Infectious Diseases. The summary is that 546 freshmen in those two classes were screened for viral capsid antibody and Epstein-Barr nuclear antigen antibody. 37% in those two classes were naive, so they'd never been infected with Epstein-Barr virus before becoming freshmen at the University of Minnesota. In over 314 person years of observation, we documented 66 infections, almost 90% of which were symptomatic. So this was probably one of the most important findings from this study. Because we had them under close surveillance, we were able to document that this virus in this age group, 18 to 22-year-olds, makes people sick. Interestingly, deep kissing was the only significant risk factor for infection. Not nutrition, not stress, not semester breaks and what have you. I'll show you a Kaplan-Meier curve of that in a bit. And then we were able to show that blood viral load, the quantity of Epstein-Barr virus in whole blood, and the CD8 lymphocytosis, okay, those are the Hal Downey cells, the atypical lymphocytes, correlated with the severity of illness. This is the infection curve where we start here with everybody naive, and if you come all the way down, it would be everybody infected. And what's interesting about this curve, very fascinating, is the freshmen had a rate of 26 cases per 100 person years, and that is statistically significantly different from the average of the sophomore, junior, and seniors that average 10 cases per year. Quite a big difference. So it tells you these are exploratory kids, and these kids have sort of learned to control themselves to a certain extent. So there's your number one risk factor. And let's look at the data again. We call these bears up here the bookworms because they have no kissing and no sexual activity. But what's very interesting is if you look at the curve of acquisition here for individuals who report deep kissing only versus those who are sexually active, there's a p-value for those two versus the bookworms positive, but there's no difference at all in these two curves. So kissing alone without other activities is sufficient to spread Epstein-Barr virus. Now, for the purposes of our studies, and this might be useful to yourselves in practice, we classified the EBV infection in 3 categories. Infectious mononucleosis, which meant that you had at least 2 of these criteria, sore throat, and this is a biggie. They often have very, very sore throats. I'm going to show you that. Cervical lymphadenopathy. You many times read that there's generalized lymphadenopathy in mono. In all the patients I've examined, that's not true. Occasionally it happens, but for the most part, this is lymphadenopathy above the neck. Fatigue. That's a tough one in college students because they're all fatigued. Fever. Now, symptomatic means that you've got something like maybe a sore throat, but you don't have at least 2 of these, but you've got some type of illness. And then asymptomatic, history completely negative, physical exam throughout the period after we recognize the infection, completely negative, and we have a few of those. In fact, we had, in the first study, 7 of the 66 were completely asymptomatic. If you're symptomatic, and 59 of the 66 were, then what do you have? Mainly sore throat, that's the big one, 93%, cervical lymphadenopathy, fatigue, fair amount of upper respiratory symptoms, but then the rest of these start coming down and down. In children, it seems like some of these things like body aches are a little bit more common. But that's what we see in individuals. Now, these are laboratory proven, prospectively shown to be due to EBV. Okay, now here's a 19-year-old boy whom I saw about a week ago on day 3 of mono. And I wanted to show you this. It's a little out of focus, but it shows you that he has this massively enlarged left tonsil, which is kind of asymmetrical. Looked at more closely, these are the bad sore throats that you see with mono. Here you've got a huge tonsil. This one's slightly enlarged, but not too bad. The uvula frequently gets very, very engorged and lengthened, and it's almost sticking on the tonsil. I see him 5 days later, and he's actually a little worse. Now the right tonsil's bigger, and you see he still has this awful-looking left tonsil, and he's hurting. He's having trouble sleeping because his throat is so sore. I do want to emphasize, though, that infectious mononucleosis is a clinical syndrome, and the cause cannot be determined without the laboratory. Even though you see a throat like this, you can't be absolutely certain that it's infectious mononucleosis due to EBV unless you do lab tests. And this is a table. First of all, I'm going to show you what we found, and then I'm going to show you the timelines of how these various virology tests change. And what we found was that, for the most part, your point-of-care test, your heterophile, your monospot test is pretty good. 82% of our subjects who were tested with it were positive. These are infectious mono. These are the ones I mentioned were symptomatic but did not fulfill the criteria for infectious mono. These 7 were completely asymptomatic. The VCA-IgM is a little bit better than the heterophile. The important thing to see here is that absolutely everybody that we have seen with primary EBV infection makes VCA-IgG antibody, but it sometimes takes a couple of months. And the majority of subjects, 96% in the mono group and a little somewhat fewer in the symptomatic and asymptomatic group, make antibody to EBNA. But a thing to remember is that EBNA antibody is slow to come up. And so if you're trying to work on a timeline and you get a VCA-IgM positive, that's early mono. If you get just an isolated VCA-IgG positive, that's kind of subacute or early convalescence. And once you see the VCA and the EBNA together, then that's convalescence and that's past infection. The other point to make here is that oral cells are always positive, and the median amount that we see in the oral cell is around 4.8 logs, which equates to about 60,000 copies of the virus per mil of saliva, so or per mil of cell pellet. So that's a lot of virus, and that stays around for a long time. Let's kind of take a look at that. What this shows is the kinetics of the amount of virus in the host and the immune response or antibody response to that. So we have EBV in the blood, which is quite short-lived. It's gone. In most patients, it's gone in about 20 days. It can sometimes persist a little longer, but that's fairly short-lived. In contrast, EBV in the oral cells or EBV in the saliva hangs around for months and months and months. And our histories tell us that most of the individuals who can recognize the donor, that is, they know who gave them mono, the donor's asymptomatic. So the donor's back in circulation. I don't have mono, but look out here, 6 months later, and they're still shedding all this virus. So in terms of the antibody response, your acute ones are, the best is the VCA-IgM, but it's not as inexpensive as the heterophile. Heterophile's next. They come up, and they're gone by 3 or 4 months. The VCA, as I've said, comes up, but many times we don't see it until about 2 months after infection. It will stay up for life, and it kind of plateaus and stays there. The EBNA comes up much more slowly and also will essentially stay up for life. So that's the kinetics or the picture that you see over time with the antibody responses and the viral loads. Now here's a little bit of work that we're doing, and it's still ongoing, to correlate what happens to make somebody sicker or less sick. And here what we're looking at is the amount of CD8 cells, the amount of CD4 cells, the amount of virus in the blood, and the amount of virus in the oral cavity correlated with severity of illness score, where 0 means you're perfectly healthy and could play football for the Gophers, 6 means you're in bed. And the strongest correlation actually was with the CD8 lymphocytosis. But I think a very important correlation is with the blood viral load, which is also significant because it gives us a target to aim at as antiviral drugs get developed. If severity of illness is related to the amount of virus in the blood, then an antiviral drug that would work against viremia would be a potentially excellent drug. All right, let's turn from the university students now to talk about some unique features and potential problems that we see in pediatrics. I think, first of all, I want to state that the true burden of disease in pediatric patients has not been determined. To do a prospective study with collection of laboratory material is very difficult, not impossible, but it's something I wish someone would do soon because we do not know the true burden of illness. It's said to be mostly asymptomatic infection. I don't believe that because clinical illness does occur, and I'm going to show you some cases in a minute, but it's usually not recognized to be due to EBV. A little pearl to take home, too, is that the laboratory diagnosis in children, particularly in children under the age of 4, may require Epstein-Barr virus specific antibody tests because the younger children frequently do not make heterotypic antibodies, so they have a negative monospot or a negative heterophile. This is a series that Chuck Horowitz put together many years ago and published in Blood of youngsters aged 10 to 24 months. So these are little kids, little toddlers for the most part. And he noticed a couple of things. One is that lymphocytosis, lymphadenopathy rather, is very common. 5 of the 8, 1, 2, 3, 4, 5, had lymphadenopathy. And as I say, this is mostly cervical lymphadenopathy. But what he showed, and this really was an excellent demonstration of this, is for the most part, these 10 to 24-month-olds don't make heterophile. Heterophile, we're looking here against guinea pigs, red blood cells, beef red blood cells, and only patient number 6 and patient number 8, and that's a weakly positive, have a positive heterophile. So 6 of the 8 subjects here, 75%, are heterophile negative, and the diagnosis needs to be made by specific antibodies or by viral loads. Now, one of the problems that we see here, and I think it's the reason that the renal group asked me to give this talk, is that visceral EBV disease in immunocompromised hosts, especially solid organ transplant patients, can be very serious, and children are particularly at risk. The main reason being the number one risk factor for serious EBV infection after transplantation is lack of EBV antibody. In other words, coming into transplant EBV negative. And as you probably know, about 90% of our donors are EBV positive, so the child is likely to get EBV that way or also could potentially get it in blood transfusions. So this is a particular problem for our pediatric transplant patients. But there are other illnesses that may be especially a problem for children, and these include multiple sclerosis, endemic Burkitt lymphoma, and nasopharyngeal carcinoma. Okay, first let me show you our data that Carol Holman published last year in Clinical Transplantation from this period of time, looking at solid organ transplants and stem cell transplants, and I circle here that the pediatric overall rate of disease during those years was significantly greater than the adult. Again, making the point that the children for post-transplant lymphoproliferative disease, or in fact for any type of EBV infection post-transplant, have a greater likelihood of having it because they come in to the transplant totally immune naive. Another thing that's not as well known perhaps, a potential problem, is that MS is linked to Epstein-Barr virus. This is an international study published in 2007, and it shows you two things. These are pediatric multiple sclerosis patients. It shows you that EBV antibody, as compared with other herpes viruses and parvovirus B19, there's a difference in the antibody prevalence in the MS patients, shown in the red bar, versus the control subjects. Now you may say, well, that's not huge, but because this is a fairly good group, there's about 100 in each group, very small p-value. So those pediatric patients who have MS are more likely, statistically significantly more likely, to have been infected with EBV before their MS. But then I think this is almost more important. This is looking at the amount of EBNA antibody they have. Now, EBNA is a gene, the protein product of which enhances latency, and it's something that marks latency of EBV, probably in the B cell. Well, when you look at the MS patients, either the absolute amount of the EBNA antibody compared with non-MS patients is significant, and the pattern, this p-value is showing the pattern of distribution, is also different, where the non-MS patients have the same likelihood of having low, moderate, or high EBNA antibody, whereas in the MS patients, 10%, 36%, and then 54% have low, moderate, and high levels. So what you're seeing is not only the antibody prevalence is higher among MS PEDS patients, but the amount of EBNA antibody is also higher. And what does that mean? I think that means that the virus is replicating and causing expression of autoimmune material, and that replication is leading to elevated EBNA titers. In terms of Burkitt and NPC, we recently reviewed a paper that's going to be published in Journal of Infectious Disease, and overall it looked at the risk of HIV, EBV co-infected infants for having very high viral loads with EBV and EBV disease. And our conclusion, also after reviewing other literature, is that it appears that early age at acquisition, particularly in infancy, active co-infection with, say, HIV and EBV or EBV and malaria, and the high blood viral load that causes impact the host's ability to control primary EBV. And in that setting, you have a very prolonged high level of exposure to the virus, which appears to be a risk factor for endemic Burkitt lymphoma and also nasopharyngeal carcinoma. And interestingly, decades ago, Guy Detay, who did a lot of epidemiology work in Africa, postulated that it was this continuous flogging of the immune system with high amounts of EBV in conjunction with holoendemic malaria that was responsible for Burkitt lymphoma. Okay, the last thing I'm going to go over with you is where do we stand with prevention and intervention? And this, in essence, is really not good news. So, like Don Quixote, are we tilting at windmills to try to even consider developing an Epstein-Barr virus vaccine? Well, here's all the problems that the vaccine has had. You cannot really infect anything other than human beings or subhuman primates with EBV. So we don't have a readily available animal model to help us develop a vaccine. Also, EBV, heck, it upregulates the immune system like the dickens, but when you try with different subunit vaccines to immunize, you have to have an adjuvant to get an immune response. And then the last problem here, I think, in early development has been that the vaccine, the best one, has ping-ponged back and forth between 3 industrial sponsors, and patent issues and arguments are actually still going on to this day. And then I think we've overcome this now. What should the vaccine achieve? The burden of disease, particularly among college students, is so high that there's no reason not to go after mono as an indication for the vaccine, although it could potentially prevent the chronic diseases we just talked about. So here are the data, the best data that we have. The candidate vaccine that's been tried in a phase 2 trial is a subunit glycoprotein 350 vaccine. GP350 is a major outside piece envelope glycoprotein of EBV. And this was a Belgian study in approximately 200 people, and the final data analysis looked at 181 of them. And what this is showing you is the vaccine is given in 3 immunizations at 0, 1, and 5 months. The placebo group is shown in the open circles. The vaccinees are shown in the solid circles. And looking over a 2-year period, there were 8 cases of mono among the placebo group, approximately 90 in each group, 2 cases of mono in the vaccine group, and this was statistically significant. But I also want to point out that 3 courses of immunization were necessary to get a decent antibody response, and so you've got a case occurring here before the 3rd immunization, 1 case there, and a case here right after the 3rd immunization. So you could argue that those 2 were probably not adequately immunized. So, I mean, this is encouraging. It was well tolerated, and immune responses were good, but it's dead in the water right now, sorry to say. We, however, did conduct a study to look at, if you were going to use EBV vaccine in the United States, when should you give it? And the way we looked at that with Larry Condon and his group is to take children 18 months to 19 who were having blood drawn for medical reasons, and to get permission to take a portion of that blood and test it for EBV antibodies, and then to call up the parents or the guardians and ask them a number of demographic and social questions that would get at risk factors. This study has just closed. It closed in mid-December, and the data are under analysis. So we only have a couple of pieces of data to share with you today, but what we can say is we got nearly 800 subjects in the study, and they covered the whole age range that we were looking for. The median age was 12. There was a slight preponderance of girls. Overall, the seroprevalence in this group was 43.6%. The curve is extremely interesting because it looks at, here's your 1.5-year-olds, here are your 19-year-olds, and it almost looks like it's got 3 phases. It's got a rapid increase in antibody for the kids 18 months to around 4 to 5, then sort of a kind of a latency or slow acquisition period, and then up it goes in the teenage years, and we all know what that's about. But here is something we didn't expect. Looking at the white children versus the black children, every dot here, except for these 2, the distance and the proportions are statistically significant. So in the Health Partners study, we've shown kind of disconcertingly that the seroprevalence, age-specific seroprevalence of EBV antibody in blacks is much higher than whites, which really confuses the issue of when you could give a vaccine. Because if you say, well, we want to immunize a group that's no more than 50% seropositive, so at least half of them could derive a benefit from a prophylactic vaccine, then for the whites, you could immunize them around age 12 at the same time they get HPV vaccine. But for the blacks right in here, it looks like you're going to have to get in at 4 or 5 years of age, and so you'd have to have different policies. Well, we're looking at multiracial children. We're looking at Hispanic children. We don't have the overall answer of what's going on with this racial disparity. The one thing I can tell you is it has something to do with household income, but that is not as strong a predictor for this difference as is race. Okay, the last thing I'm going to mention is if we don't have a vaccine, and it looks like we're not going to get one for a while, what can we do to intervene, to treat? In the immunocompetent host, there's the possibility of using valacyclovir. It's just gone generic a year or 2 ago, so it's not terribly expensive. Whether it works or not, we don't totally know because there's been no rigorous clinical trial done. In the immunocompromised host, I think there's no question of a doubt that the first thing that's done is to reduce immunosuppression, and even in cases of potential PTLD, that might be enough. If it isn't, then antiviral drugs are often employed, particularly ganciclovir or valganciclovir. And then the most drastic thing, of course, is to use anti-CD20 antibody, rituximab. It's expensive, and it causes a fairly profound and persistent lymphopenia and decreased B cells. One thing we're hoping to do, though, to study prophylaxis of both CMV and EBV infections post-transplant, and I'm doing this in conjunction with Priya, is to look at head-to-head valganciclovir versus valacyclovir post-transplant. I just show you some in vitro data here arguing that if you look at the cell line, The median sensitivity in cell lines to acyclovir, this is EBV, is 3.4 micromolar, and for ganciclovir it's 2.6 micromolar. Ganciclovir is better, but not, tremendously better. And in subject cell lines, these are subjects with mono, and we've immortalized their cells, and we're using them to test. 2.5 micromolar is what we would see as an in vitro IC50 versus around 1.7 for GAN. These numbers are easily achievable by oral dosing. The other thing I would say is that for the Val-GAN recipients, solid organ patients getting that, we very frequently do not see the full recommended adult dose of 450 twice a day because of leukopenia and other issues that cause the patients or their physicians to dose reduce, at which point they may well be under the effective therapeutic or even prophylactic level, so we're exposing the virus to the potential of developing resistance. Okay, here's what I've told you in summary. The clinical picture of the fever, lymphadenopathy, fatigue, and sore throat, the atypical lymphocytes, and the heterophile monospot reaction were all described about 40 years before EBV was actually discovered and then found to be the major cause. The number one risk factor for infection is deep kissing, and the riskiest college year is the freshman year. Most of our college students studied prospectively were symptomatic, and I've shown you that the blood viral load and the CD8 lymphocytosis, these are the atypical lymphocytes, correlates with the severity of illness. Mono, due to EBV, is a laboratory diagnosis in the acute phase. The point-of-care heterophile test or the VCA-IgM are the things to use. Subacute isolated VCA-IgG positivity would point to that. Past infection, almost everybody would have VCA and EBNA-IgG. In children, we don't know the true burden of illness. This is something for some of you out there maybe to discover. Children may, especially young ones, be heterophile negative. An early infection in childhood or infection in conjunction with a co-infection, such as we see in the African children, is a risk factor for chronic illnesses such as multiple sclerosis, Burkitt lymphoma, nasopharyngeal carcinoma. And children, after transplantation, bone marrow or solid organ, are at higher risk than adults for post-transplant EBV disease. A GP350 subunit vaccine has shown promise in preventing mono, but right now the vaccine is on hold and we're not certain when to give it. We're still working on that. Interventions have not shown efficacy in rigorous clinical trials, and so as I end, I will come back to the next to last point and hope that as we move forward, somehow, some way, we're going to be able to develop an EBV vaccine, because I think that all the action is there as far as preventing some of these absolutely horrendous diseases. Thank you very much. Cliff.
If someone did want to do a prospective study in pediatric population, would examining oral cells for EBV virus be as sensitive and specific as antibody type?
Right. Yeah, Cliff's question is a very good one, and one we've contemplated, and I'll elaborate. What he's saying is if you were going to do a prospective study to try to get at the disease burden in children, could you simply do throat washings and look for virus? And actually, Larry is here, Larry Condon and I talked about picking out maybe a couple of daycare centers where we could look at this, and I think it's a great idea. One of the problems, though, is that somehow, I think, we're going to have to, and maybe we have enough subjects to do this, we would have to connect that oral viral load, with the symptomatic illness. And if we don't have any blood data, it might be a little bit of a stretch, although not impossible. So that's a good point. Yes, sir?
Is there any role for the swab in the clinical diagnosis of EBV?
You mean to get the, to do
You
it?
the blood quite often, and it's often come negative.
Yes, yes. Okay, there's a group, I think in Stillwater, that always sends us, they don't like the heterophiles, so they send us blood for diagnosing mono. And you're absolutely right. The problem is the viremia is very short-lived. And in our most recent study, the class 2016, these kids were pushing the assay. And so these kids may only have 200 or 500 copies in the blood, and it's short-lived. So the throat would be better. And if you wanted to do that, the only problem I see is we do have some people with pretty high oral loads running around who don't have mono, so you could get a little confused there. But if you have the clinical illness and you have a lot of virus in the oral cavity, yeah, you could definitely make the diagnosis that way. Yes, you could. Yes. Yes.
I'm a rheumatologist, and a frequent reason for referral to our clinics is that the adolescent has prolonged fatigue and sort of a low positive ANA. Frequently, those patients will have a history of EBV or mono within the past 3 to 6 months. Do you have information about how common prolonged fatigue or positive ANA are from your study of the college students?
We have not looked at that specifically in the college students, so I can't answer that for you. I can tell you that some of the chronic fatigue patients that we've seen, if we're going to treat them, we've said, well, we really want to see if there's any viral load there. And we have not been able to demonstrate EBV viral load in the throat or the blood of these patients. So it could still be EBV driven, but I don't think at that stage there's enough active viral replication, to go after if you're going to try to say, okay, I want an antiviral to do my job. Yes?
Will revving up the NK cells make therapy worse or better?
The NK cells go up, Harvey, just like the CD8 lymphocytes. So you would argue, in acute mono, so you would think that if you rev them up some more, that would be helpful because that's the normal immune response. Actually, those studies that we're doing with the CD8, CD4s, NK cells, and we're looking at cytokines as well, that whole idea would be if we have a vaccine, can we see what the vaccine does to that stuff? And if it upregulates it, then we would say it's a good vaccine. I think it would help to jazz up the NK cells because that's what the normal host does. The CD4s are absolutely flat, as you probably saw that curve. Yes?
In terms of vaccine development, is there any focus on mucosal administration?
There hasn't been, actually. It's a funny thing that for a long time, people didn't even think the oral epithelial cells were infected. They thought that all the EBV was coming out through intermittent B cell shedding and blood. Now it's pretty darn clear that the oral cells are infected. And so a person could argue that you could try to stimulate, secretory antibody, stuff like that with an oral vaccine. But all the work that's been done, there's been work in 2 camps. One has been the GP350 vaccine, and the other one has been trying to rev up specific immune recognition with CTL cells. But then that stuff has to be HLA matched, and it's a pain and it's expensive. So it's not a very practical approach in general for immunization. Yes?
So in some of our solid organ transplant patients, we have seroconversion of the antibodies, but we don't detect the virus by PCR in the blood. So would you consider those patients infected, and how long would you say? Would you wait until their IgM level comes down, or?
Yeah. I think the biggest issue with the seroconversion, in my mind, is to be sure that it's not passively transferred, because some of the, particularly children, get blood products. If that's not the case, then that's probably a good thing, because it means that they all have viremia, but it may have been such a short, if you test them every month or every 2 months, you're going to miss it for the most part if it's short-lived. I would say, okay, they've been infected, and you may want to, what I usually tell people is to monitor the blood viral load then, because you don't care what's going on with the antibody, but you sure care if they're viremic, because then that's a harbinger of potentially tissue-invasive disease. So that's what I would do. And I might monitor them frequently. If they just seroconverted, maybe every month, and then after that for 3 to 6 months, something like that. Yeah. Yes. Yes, Blanche.
Are you treating your symptomatic college students?
We are not. We are not. We are not treating our symptomatic students. We thought about it, but what we have tried to do very carefully in those studies is to separate the research component from the clinical care. And so, like, for example, that throat that I showed you walked over to the emergency room on Saturday because he was so sick. And they gave him steroids, which I don't like, but that's care. And so we have not done that. We will prescribe, if they can't get in to be seen, yes, we will prescribe, how shall I say, a sort of palliative stuff. But we have not used valacyclovir in this subject population. You might ask me why. I mean, I believe that it has a place to play. But since it is not, how shall I put it, standard of care, I think we're better off doing a natural history study to leave it as a natural history study. Although it's not none of these are perfect, because someone goes to the ER and gets prednisone, and so that's different from someone who's got a sore throat and toughs it out, but that's what we have to work with.
Do you think those get prednisone shed it longer? I mean, do they have any evidence?
They do. We know that. But we couldn't get it published because they told us the paper was too long. So we have a little piece of information that's really cool. And again, it wasn't controlled. But when we took a group of subjects who were treated by Boynton Health Service, the treatment seemed to be more doctor-associated than sickness-associated. In other words, some docs use prednisone, don't. But then we said, okay, we have a group. We had 10 that had prednisone and 10 didn't. And the viremia phase is higher and longer in the prednisone-treated kids. But the criticism was that this is not controlled, and the paper's too long, so take it out. So we took it out. But that's what we found.
When you found those kids who got the prednisone, did they get their symptoms resolved faster, or did it make it?
I think it reduces the swelling. And so, you know, if you've got somebody with, well, we've seen some uvulas that are about that long, and you know, they're better when they get prednisone. But very short tapering course, yeah. I think that works. But it does upregulate, I mean, it does assist the virus in its replication, that is for sure. So what do you want? You pay, you know, it's a catch-22. It's a catch-22. Okay, thanks very much.